He has applied these techniques especially to the study of the overdose crisis in the US and Mexico, and to documenting rapidly emerging trends and inequalities in socially bound causes of mortality. His first author peer-reviewed articles have been published in journals including JAMA, Nature, The Lancet, JAMA Psychiatry, the American Journal of Psychiatry, and Addiction, and his popular press writings have appeared in venues such as the LA Times, Los Angeles Times, Time Magazine, and The Nation. His dissertation fieldwork was conducted on the US Mexico border, working with individuals who inject fentanyl and methamphetamine, many of whom were deported from the United States after developing a substance use disorder. All right.
Thanks so much for having me. So I'll jump right in. We have an hour, right? In total, more or less?
Yes, till 1 o'clock.
Great. So I'm going to be talking about novel synthetics, polysubstance use, counterfeit pills, and social inequalities, rapid shifts in the US overdose crisis. So throughout the talk, I'm going to use QR codes for reference. So if you see some data or an article that you find interesting, you can just open your phone camera and access it that way. So the first thing I want to say about the US overdose crisis is that it really is a uniquely American problem, and we're in kind of a profound moment in terms of this crisis as a country. So here's some data from the top 10 countries most affected by drug overdose as a cause of death. Data only run through 2019. And you can see that around the early 2000s, the US really broke away from the rest of the pack and became by far the most affected country in the world by drug overdose deaths. Currently, we're probably something like 20 to 30 times higher than the world average. We're something like 2 to 3 times more affected than the next most affected country. So this is really a unique problem in our country. This is some data from a paper that made a big splash a couple of years ago by basically showing that the overdose crisis in the US has gotten worse in an exponential fashion year after year for about 4 decades. So on the right, you can see the per capita overdose mortality rate going up in a really smooth fashion year after year for 4 decades. But on the left, you can see that there's actually a number of different drugs that have been involved in drug overdose deaths over time. And so all of these little kind of subcomponent drug overdose crises have added up to this smooth and continuously worsening crisis in our country. And in terms of categorizing these kind of phases of the overall crisis, we like to talk about 4 waves. So the first wave started in approximately the early 2000s with the rise in deaths involving prescription opioids. So you can see that here in green, and basically deaths involving prescription opioids started to rise and reached a plateau in about 2010. So I think a lot of us know there's been a strong crackdown on the prescribing of opioids, and so deaths involving these kinds of opioids have now started to go down. In response to crackdowns on prescription opioids, deaths involving heroin started to rise in about 2010, reaching a plateau in 2015, and have now gone down sharply. Wave 3 involved deaths involving illicitly manufactured fentanyls in blue. And here in blue, I'm showing specifically fentanyl deaths that don't involve stimulants. Those really started to rise in 2013, and you can see kind of immediately kind of blew everything else out of the water, became, by far this kind of unique, kind of profound amount of death that had never been seen before. And just a few years later, fentanyl deaths also involving stimulants started to rise. And so this is kind of the 4th wave now, where people are dying not just from fentanyl, but really from fentanyl that's being mixed with other things, especially stimulants, but also a lot of other drug classes that we're going to talk about today. So these are kind of this is the big picture of the overdose crisis. I also wanted to pull some of the latest numbers from Idaho, and hopefully this can be useful for people in your program. So you can see here the number of overdose deaths per year from 1999 to 2022. And we can see that, Idaho has not been spared in terms of the U.S. overdose crisis by any means. Deaths have increased by approximately sevenfold over the past 2 decades, and about doubled over the last decade. So it's certainly a problem. And in terms of which drugs have been involved, this is kind of a snapshot of the last 3 years, the latest 3 years of data that we have. These are probably slight undercounts just because of difficulties in detection and in autopsies. But what we can see is that about 40% of overdose deaths in Idaho involved fentanyl, 35% involved methamphetamine, 25% involved prescription opioids, and then so on and so forth: benzodiazepines, ethanol, heroin, methadone, and cocaine. So I think this is pretty similar to the national profile. There's probably a little bit more involvement of prescription opioids in Idaho than compared to the national average, which I think is kind of interesting. So beyond just the mix of fentanyl and stimulants, which is something that I'm sure you're all seeing in the field, I would actually give kind of the following characteristics to describe what is the fourth wave of the overdose crisis. So the key thing is that the base is illicitly manufactured fentanyl. This is kind of really driving what's happening. And a lot of what we're seeing is actually kind of a response to the market takeover of fentanyl. Polysubstance use is becoming the norm. So people are much more rarely just using fentanyl. Most people are switching to using fentanyl and stimulants, as well as a number of other classes of drugs. Counterfeit formulations are becoming really widespread. And we're seeing sharply rising racial and ethnic disparities in the overdose crisis. So just quickly to kind of touch on some of the key points about fentanyl, as I think everyone in the audience knows, fentanyls are a family of synthetic opioid agonists, many times stronger than traditional heroin. The MME is something like 50 to 100. So this is something that's a lot stronger than many of the opioids that people are used to using. And really, fentanyls have changed the risk environment for people who use drugs in a few different ways. The obvious one is that they're so strong that it's easy to overdose with small variations in quantity. But there's another really important dynamic, which is that because fentanyls tend to have shorter half-lives than heroin and other opioids, people are having to inject or dose far more frequently. So multiple times per day, which really changes like the logistics of what it looks like to be someone who's physically dependent on opioids. Fentanyls were initially concentrated in the eastern US, but have now been rapidly spreading to the west. And actually, really, I think there's almost no pockets left in the US that don't have fentanyl. And of course, as we all know, fentanyl has been used for decades very safely in hospital settings. So that's not really what's causing the overdose crisis. The problem is that in an illicit market, we don't have quality controls, and so people struggle to dose accurately every time. Here's a histogram showing the data from British Columbia and Canada from a drug checking program where people bring in samples of the opioid or fentanyl or heroin that they're sold on the street, and they're quantifying what % of that sample was fentanyl. And you can see that the bulk of the samples that are brought in are something like 5 to 15% fentanyl. This is what people are expecting. But the really lethal aspect of the situation is this long tail, right? Like sometimes people are bringing in these samples and they have 30 or 45 or up 75% fentanyl. And so I would kind of equate this to like you go into a bar and you order a beer or you order a mixed drink and you don't know if it's going to have like half a shot of alcohol or if it's going to have like 20 shots of alcohol. And the only way to find out is basically to either bring it to like a fancy drug checking program, which you may or may not have access to, or you just start drinking it and see what happens. And if that were the case, we'd probably have a lot of overdose deaths related to alcohol. So polysubstance use. So I think the key thing to understand is that we're really in the age of fentanyl and stimulants. So here you can see kind of all of the overdose deaths in the US by year from 2010 to 2021. There's the height of the bars going up, showing the number of overdose deaths going up in the US. You can see in yellow the proportion of overdose deaths that did not involve fentanyl or stimulants. In red, you can see the proportion that had stimulants with no fentanyl. Purple is fentanyl with stimulants, and blue is fentanyl without stimulants. So back in 2010, the vast majority of deaths in the US did not involve either fentanyl or stimulants. But over time, we've seen that fraction has shrunk to only 16%. And by far the fastest growing component here is fentanyl with stimulants in purple. And really, it's slated to become kind of the largest fraction of the overdose crisis, is people dying with both of these things on board. This is kind of a high dimensional graph, so I'll apologize, but basically the point of this graph is just showing the transition of what people are using fentanyl with. So we have every state on the y-axis organized into major regions, so Midwest, West, Northeast, and South. And the different colors just show what are people using fentanyl with, right? What is fentanyl being found alongside in overdose deaths? And what we can see, and here's Idaho, by the way. So what we can see is that back in 2010, fentanyl was mostly used with alcohol, which is shown in blue. That was the case in Idaho, or with prescription opioids in red in a lot of the country, sometimes with cocaine. But over the past 12 years or so, we've seen a shift in every single state to now the most common thing is either methamphetamine in orange, which is the case in most of the country, certainly in Idaho, everywhere in the West, or in the Northeast, it's still cocaine. It's fentanyl being mixed with cocaine. The Northeast just has like a really firmly entrenched cocaine market that has not been displaced by methamphetamine yet, but certainly there are signs that that's happening. And this is a graph showing every single state in terms of the percent of fentanyl deaths that have stimulants on board. And you can see each year from 2015 to 2021 is a dot. And so as we go from blue to red, we're moving forward into the future, or forward closer to the present, rather. And you can see in every single state, the fraction of fentanyl deaths involving stimulants is going up. Idaho is actually on the lower end, way down here, because these are sorted by the latest year of data. So you have a little bit less polysubstance use than other places, but still we're talking about something like 50 to 60% of deaths, right? And so this is becoming a national phenomenon. And I think this is a really interesting question that that I've tried to look at in more qualitative research of why are people turning to polysubstance use? So one thing is that a lot of it is unintentional. So this is a single drug sample that was submitted to a drug checking program in Chicago. And the contents of this is sold as like down or fentanyl or heroin, right? Just sold as kind of this like generic opioid product that's probably the only thing the person had access to at that time. And this contained diphenhydramine, several different fentanyl analogs of varying potency, a novel synthetic benzodiazepine, cocaine, xylazine, classic fentanyl, right? It's kind of this like impressive collection of substances that this person was consuming. And so this is so different than just using fentanyl or just using heroin. And this is really becoming the norm for a lot of people, that they're just buying these prepackaged formulations and they probably have no idea what they're consuming. And then there's also a lot of intentional polysubstance use. And I think the theme that there's a lot of different reasons that people have for using stimulants and opioids. Of course, people have, been doing speedballs and using heroin and cocaine for decades, but it is really changing in terms of the magnitude now. And the thing that continues to come up time and time again in qualitative research is that polysubstance use is a way to kind of modify or adapt to the downsides of fentanyl, right? Fentanyl's taking over the market, it's unavoidable. And but it has these profound kind of disadvantages that people don't like. And one of them is that it's really short acting. So here is a representative quote from someone who I've just called Susie. She's 24, she's white, she lives in Philadelphia, and she injects opioids and methamphetamine. And she said, fentanyl is so short-lived that we got to get high every 6 hours. But sometimes, let's just say, things are tough or whatever. If we're 10 hours in and you start getting sick, a nice shot of meth will hold you over for another 6 hours, as far as not being sick altogether. You just wouldn't be as sick. I mean, eventually it would turn against you, but it would keep you feeling better to get up and make a move to make money. And this comes up a lot, like basically that a lot of the substances that are spreading and being used with fentanyl, like methamphetamine, like xylazine, which we'll talk about in a minute, are being used to kind of stretch out the effect of fentanyl and help people, for example, be able to sleep through the night instead of waking up in the middle of the night, or be able to like work a full shift in their job to make money, things like that. So moving into xylazine, this is a substance that has been in the news a lot. There's been a ton of scaremongering and like these really ridiculous kind of headlines about zombies and things like that. And here's some of those headlines. Here you can see Chuck Schumer holding up a big picture of a xylazine bottle, which I thought was funny because it's definitely not what the like illicit xylazine looks like. And I'm going to share some data from this mixed method study that I worked on last year, where we basically kind of documented xylazine spreading across the US and some of the reasons why it's being used. This is a picture of the ethnographic field site where we first kind of gathered a lot of qualitative insights by spending time longitudinally with people who use xylazine. Some background information is that xylazine is a veterinary sedative. It's not approved for human consumption. Basically, the FDA, did not approve it decades ago, but said it was safe enough for animals. It's an alpha-2 adrenergic agonist. It's similar to clonidine. Basically, it's just an anesthetic, right? It just causes you to pass out. And the full receptor activity is actually unknown. It's still a matter of scientific debate. In humans, it's very hard to study for obvious reasons. It was initially started to be mixed into the illicit opioid supply in Puerto Rico about 2 decades ago. And then in kind of the late 2010s, it seemed to jump to mainland US. It was noticed by our ethnographic team, basically meaning team of anthropologists in Philadelphia in the late 2010s. And this prompted us to kind of systematically search for data all across the country showing us where xylazine is spreading, because unfortunately, it's not something that's comprehensively tracked by the CDC. So on the demand for xylazine, again, people mention that what they like about it is that it prolongs the onset of withdrawal symptoms. So this person said, I like xylazine because fentanyl is such a short-lived high. The nod is over real quick and you get sicker faster. See, the tranq, which is xylazine, extends the high. It gives the dope more of a heroin-like effect. And people talk about this, that like, adding a little bit of xylazine into your fentanyl somehow makes it feel like the good old days of heroin, and this kind of like very dystopian, there's just like the kind of like adding like a nice sauce to your McDonald's to kind of get back to like a real meal kind of thing. There's also this really clear trend of soft tissue infection where people talk about, like here's one quote where this person said, I got some friends out here that got really torn up by it. They got holes in them, abscesses. Basically, it's like the body is rotting. People here are losing limbs, like with gangrene. Whatever they're doing with the tranq, everybody is getting these scabby sores all over their bodies. And this is something you see in qualitative literature from kind of everywhere that xylazine lands. It's not something that's well understood pharmacologically. On the risk of overdose, this is a harm reductionist in Philly who said, the number of people I was reversing, meaning administering naloxone to, was definitely going up. There were people who would become only minimally alert and be only slightly responsive to Narcan. So that definitely concerned us that something different was happening, that there were non-opioid agents involved. We did a lot of Narcan training, and we had to focus more on the necessity of doing rescue breaths instead of just Narcan. So clearly kind of changing the risk environment. And here we can see the result of our national data search. So basically, the CDC is not kind of providing a nice graph like I've been showing for fentanyl and other substances of like, where is xylazine and the prevalence over time. And so we ultimately looked for data from coroners and medical examiners, people who were tracking xylazine, and we found that it was present in at least 10 jurisdictions, so cities and states. And among those places, the prevalence, or among the places that we could find data for, the prevalence rose from about 4% of overdose deaths in 2015 to 6.7% in 2020. So, and here you can see the kind of number of deaths in each of the places where we found data. And basically, we found that where it landed, it tended to increase exponentially over the next couple of years. And we're still seeing that now, unfortunately. The geographic distribution of xylazine really mimics the spread of fentanyl, but on like a 10-year lag. So it's most concentrated in the Northeast, just like fentanyl was 10 years ago, and it's kind of spreading out to the rest of the country in this way that I think makes sense, because it's found in almost 100% of the cases where we found xylazine, it's found with fentanyl. People are not really just using xylazine by itself. to like knock themselves out, or, you know, to be anesthetized. They're using it to modify the effect of fentanyl. In terms of federal data, unfortunately, there's just like the CDC's kind of crumbling public health infrastructure is really not set up to track all of the novel substances that were being detected. There are something like 2,000 to 3,000 jurisdictions of medical examiners and coroners all over the country that independently decide what substances they look for when they do comprehensive toxicology versus limited toxicology, and what kinds of deaths, and all of that kind of messy picture gets aggregated up to the CDC, to these little boxes like heroin and cocaine. And we don't have a system to track the, you know, all of the different fentanyl analogs and the novel synthetic benzos and kind of all of these things that we simply just don't have, you know, the right kind of database to track them, as kind of simple as that sounds. And so we really don't know the degree to which these novel substances are spreading across the country because unfortunately we don't have the database. We do have a few kind of responses. There's something called SUDORs, which is this incomplete picture of overdose death data with more detail. And one study from 2019, so really early in the crisis, right, kind of before things started to increase exponentially, found that it was already present in 25 out of 38 states. So there's evidence that this is kind of all over the country. There's also been documented evidence that xylazine is both sometimes diverted from the veterinary supply, so people like taking the bottle off the shelf, you know, in the vet pharmacy kind of thing, and also being imported en masse like fentanyl through the southern border. So they've kind of seized, you know, large amounts of xylazine at the border. So it's happening in both ways. And I think more broadly, what we can learn from xylazine is basically that fentanyl is beyond just causing a lot of deaths itself. It's really ushering in a new wave, a kind of a new era of what illicit drug use looks like in the US, where there's all of these new synthetic drugs across numerous drug classes, novel synthetic benzodiazepines, novel synthetic cannabinoids, that are being synthesized and mixed in with the opioid supply in this kind of free market race to see which products perform the best, right? And unfortunately, there are not a lot of regulations or mechanisms in place to protect the consumers of these products. You could also imagine how the barrier would be lowered to producing synthetic drugs in general, because we've moved from heroin, which is produced in a field, which requires agricultural labor and minimal processing, to fentanyl, which is produced in a lab. It just requires precursors and people who know about organic chemistry, and it's an easy thing to synthesize. So we've kind of dramatically shifted the entire kind of pipeline, the kind of supply chain of illicit opioids in the US. So moving into counterfeit formulations. And basically the take-home point here is that an increasing fraction of fentanyl is being sold as counterfeit pills. So initially fentanyls were being sold in powder form that were being added to powder heroin and kind of replacing drugs that were sold as powders. But now it's just being pressed into pills. You can actually buy these pill presses on Alibaba for not that much money and have them shipped to your house. And you can watch videos on YouTube from like Vice investigations of people dumping the fentanyl powder into the pill press, and it pops out and it looks exactly like an authentic oxycodone pill. It's really uncanny how well these things work. And so here's just some data showing this point. So the fraction of fentanyl seized by like the DEA and on the border, so, you know, maybe not the best measure, but some kind of measure that was in pill form rose from 14% in 2018 to 30% in 2021 and just continues to climb. So here are some pictures of fake, and this is authentic oxycodone and this is counterfeit oxycodone. You know, I have done research with these pills, touched them, looked at them, and I cannot tell the difference without using a $40,000 piece of drug checking technology. And I think most consumers would be in a similar position. Here's authentic and counterfeit Xanax. Becoming really important is counterfeit Adderall. There's like these massive Adderall shortages all over the country, and people are increasingly, really, they think they're consuming Adderall, but really it's just methamphetamine. So I think one of the real tragedies of counterfeit pills is it kind of expands the market for fentanyls, right? There are a lot of people who would never, who use drugs, would willingly use some kinds of drugs, but would never use fentanyl. And I think because a pill, just having that powder pressed into a pill, it kind of confers some perception of like medical authority and safety. And unfortunately, one of the populations that's now being swept up into the overdose crisis is high school age teenagers. Here's an LA Times headline: "One pill kills, students overdose death prompts urgent action among educators and police." So this is right here in LA County. There have been a huge number of overdose deaths. I think I just saw the headline yesterday that in the LA Unified School District just started carrying Narcan, and in the past year, they've used it like 31 times on campus. So this is really becoming like a profound crisis among high school age teenagers. Here's some data from an article that we published last year showing, basically over time, even as we saw that the overdose death rate among adults has been going up year after year after year. For most of the data we have, for most of history, teens were just insulated from that because they're just not experimenting with the most dangerous kinds of drugs, right? They're just not using heroin. They're not really using powder drugs that frequently. It's mostly alcohol and cannabis and prescription drugs. And so as these prescription drugs are becoming replaced with illicit fentanyls, which is the overdose death category here, we have just seen this kind of sharp increase in teenage deaths. I think drug overdose death is now the third leading cause of pediatric deaths after firearms and motor vehicle accidents. So it's unfortunately sharply on the increase still today. Another population that is being swept up into this is kind of older people who really like taking prescription drugs and are getting cut off by their doctors. And one population, one subset of that group of people go to Mexico to try and get these drugs in other ways without a prescription from a U.S. doctor. This is a LA Times cover page, and it shows this story. Mexican pharmacies sell fentanyl and meth-tainted pills. And they're citing both an independent investigation they did and also this study that we put out called "Fentanyl, Heroin, and Methamphetamine-Based Counterfeit Pills Sold at Tourist-Oriented Pharmacies in Mexico, an ethnographic and drug checking study," where we basically found that if you go to independent pharmacies in Cabo or in a variety of cities in Mexico that cater to tourists, you can find, it's kind of long been known that you can access Xanax and, opioids and all kinds of substances without a prescription from a doctor, which is in flagrant violation of Mexican law, but is simply not enforced. And we found both authentic and counterfeit pills. And here you can see some examples of Adderall and oxycodone. Sometimes even in the same store, you could get authentic and counterfeit oxycodone, and the only way to tell the difference is with drug checking technology, which most people don't have access to. And in some cases, we even found counterfeit oxycodone that actually contained heroin, which is kind of especially scary because, and the way we found it is that an ethnographic participant told us like, "Hey, this pill, this person is like pretty well informed and used a fentanyl testing strip on this pill and still found it to be far too strong and, almost overdosed. And so submitted it to us. We use a much more sophisticated kind of technology. We find it contains heroin. And this is the kind of difficulty involved in avoiding risk these days." And here you can see a picture of an example of one of what these pharmacies look like. All of the words are in English. This says the name of this pharmacy is Meds for Less. And you can see it says on the window, painkillers, all in English, antibiotics, somas, sleeping pills, ivermectin. I thought that was kind of a good one. And of course, Viagra. So now sharply rising racial and ethnic disparities. So this part of the talk, I think, gets a little bit more into some of the social theory and the way that the American public has kind of understood the overdose crisis. So here I'm showing kind of for a number of different substances, like all opioids, cocaine, fentanyl, synthetic opioids, heroin, I'm showing the different kind of racial and ethnic pattern, right? And so what we see is that drug use in the US and the overdose crisis is really racially patterned. It just does not affect different people from different groups in the same way. And here you can see non-Hispanic white people are in red, non-Hispanic American Indians or Alaskan Natives are in purple, non-Hispanic Black individuals are in blue, Latinx individuals are in green, and the non-Hispanic Asian or Pacific Islanders are in orange. So although we're talking about 4 waves of the overdose crisis, I kind of like to include this wave 0, which is actually back before the US kind of broke away from the pack, where the most common thing that was the most common drug involved in overdose deaths was cocaine. And I think the kind of American public just associates cocaine with Black and African American people. It's just like one of these deeply kind of entrenched associations that we have, at least certain kinds of cocaine. And back when cocaine was the dominant thing that people were dying from, the dominant response was just say no, and Nancy Reagan, and mass incarceration, and a very heavy kind of law enforcement oriented approach, right? Where sentences were kind of dramatically increased, and the number of people who were incarcerated for drug use or possession or low-level sales kind of ballooned. And that really changed when prescription opioids became the #1 thing that people were dying from. And so, there's been a lot of really good social science research about the kind of transition to the medicalization or the humanization of addiction, where people suffering with substance use disorders became patients instead of criminals, right? And you can see that a big part of that was this perception and the reality that white individuals were heavily affected by the prescription, by the kind of the first wave of the overdose crisis. I would want to highlight that Native individuals were affected just as much as white individuals, but that was definitely not kind of the public perception, right? Where there's kind of this big gap where white individuals were like 500% more affected by prescription overdose deaths. And you see this in headlines from like the 2010 to 2015 period, where there's kind of like the public is grappling with the idea that like, wow, there's this white problem in our midst, which is addiction and overdose. Here's some real headlines from this time. Heroin in suburbia, a new face of addiction. Police say heroin is attracting young middle-class suburban users. And even though they don't say white, this is heavily coded language, right? Everybody kind of knows what this means. Sometimes they say it more explicitly when a drug epidemic's victims are white. And here at this link in this QR code, there's a really good kind of article from some kind of scholars on this topic that I think is definitely worth a read. And I'll circulate these slides so you can also get it later. And a big part of this perception of this kind of whiteness of this crisis relates to this concept called the deaths of despair, which I imagine that a lot of people have heard of. It's been like phenomenally successful as a social science theory in just like invading kind of everybody's consciousness. It went out like, this is a paper published by 2 economists that immediately was like covered on CNN, and famously, as soon as this paper came out, it's published by these 2 economists, Case and Deaton, that are at Princeton, and like as soon as this paper came out, Angus Deaton, who's like a Nobel Prize winner, like met with Obama for some other reason, and Obama was like immediately wanted to talk about the paper. So this concept like really kind of fills the airwaves, and everybody knew about it. And this is kind of the most famous graph from this paper. And they showed midlife mortality, so age 45 to 54, which is this age where it's kind of the last age group where ideally nobody dies from, for like most of the people dying in this age group are dying from extremely preventable things. And they show data from all of these countries, France and Germany and the UK and Canada, where like mortality in midlife years is going down. We're getting better at preventing deaths, which means life expectancy is going up. For US Hispanic individuals, they show the line going down. And then for US white individuals, they show the line kind of appearing to go up, right? It's like this really dramatic thing, like the whole world is getting better and only white people in the US are not getting better, is kind of the message. And this is what really kind of fascinated the American public and got a lot of coverage to this story. And if you look at the title, it's very racialized, right? It's literally saying rising morbidity and mortality in midlife people among white non-Hispanic Americans. So this very clearly, this was the selling point. And this is a recreation of this graph that I worked on with some colleagues, and that was published recently. And it's the same data. It is extended through 2020. But you can see that same line, the same red line for white individuals is here. And you can see it is flattening out, right? This is a very real thing. And the data for Hispanic people is going down. But they didn't print the line for Black Americans here in blue. And they did an interview about why they didn't do that. And they were like, well, it just didn't fit on the graph, right? It was like, it just didn't fit. And it certainly is much higher, right? And I think the critique is that, you know, it is that there's this very small, like 5 or 10% increase in midlife mortality among white people, which is important. We should definitely care about it and work on it. But that delta is so much smaller than this kind of massive gap between Black and white individuals. And they also said, well, you know, midlife mortality among Black people is going down. And at the time of their study, it had kind of bottomed out. And unfortunately, it's just really flattened out in the preceding years. And so now we just have this kind of fixed, huge inequality. And midlife mortality among Native Americans was higher in the study used data through 2013. Midlife mortality among Native Americans was also not shown, was also going up to a far greater degree. So I think the argument that we're looking at kind of deaths that were going up, it really excluded information from Native Americans. And unfortunately, midlife deaths among Native Americans have just gone up to an extreme degree. And so there's some really important kind of inequalities in deaths that were missing by the deaths of despair narrative. But it is interesting to ask ourselves, why is it that prescription opioid deaths disproportionately affected white people? I think it's a sociologically very interesting question. And this is some research that I worked on that tried to assess this question. So this is data from California, from the first wave of the overdose crisis in California. And on the left, we're kind of representing the whole state of California, organizing everybody by race and income. And you can see, so there's kind of quintiles of race. So as you kind of move up through the graph, you're moving into like whiter and whiter neighborhoods of California. And as you move to the right, you're moving into wealthier and wealthier neighborhoods of California. And you can see that overdose deaths were dramatically concentrated in low-income white parts of California at this time. This has completely changed now. But in wave one of the overdose crisis, this was what it looked like. And if you look, then we used CURES, which is the prescription drug monitoring program for California, to track kind of every controlled substance prescription in the state. And you could see that opioid prescriptions were also dramatically concentrated in low-income white communities, right? With something like a 300% gap in the percent of people in a given area, in a given neighborhood, who received any opioid each year from a doctor, just based on their race and income. And obviously, I don't think there's a 300% difference in the underlying rate of pain. So something is happening where different kinds of people tend to have really different access to legal drugs through the healthcare system, as opposed to illegal drugs through the kind of street market. Just for curiosity, I think it's interesting to look at and I think pretty relevant to psychiatrists, right? To look at the kind of racial and income gradient of benzodiazepine prescriptions. And again, in California, there's a 300% gradient just based on how white the neighborhood is on how many benzos are being prescribed, where it's, something like 15% of people in the whitest areas and like 5% of people in the least white areas of California get a benzo each year from their doctor, from any doctor. We also mapped out at the zip code level where people are getting different controlled substances through the healthcare system. So for those of you who don't know the ins and outs of the LA metro area, this is basically the percent of individuals that identify as white. This is Malibu here, 82% white, Beverly Hills, 83% white. Basically all the wealth and kind of a lot of non-Hispanic white individuals are concentrated on the coast, right? And then this is Watson Compton here in kind of South Central LA, right? Kind of Central LA. And you can see race and income line up really well. And in LA, as a deeply kind of racially segregated place with a lot of inequalities, and benzodiazepine and stimulant prescription prevalence also line up remarkably well with race and income. So 27% of people in Beverly Hills get a benzo each year from their doctor, compared to 5% of people in Watts. And for stimulants, it's 6% of people in Beverly Hills and about 0.4% of people in Watts. So I do think there's something kind of really sociologically interesting happening here that tells us a lot about our society. But moving on, the days of white people being more affected by opioid overdose are long gone. And basically, with the rise of fentanyl, Black and Native individuals have been disproportionately affected by opioid overdose. And I think in the latest data, it's something like 20 or 30% higher among Black individuals relative to white, and 50% higher among Native individuals relative to white individuals. So we've kind of come full circle. And I think this kind of interesting, phenomenon of like the kind of white overdose thing is just empirically is kind of gone away. But one thing that is really important is that the perception of kind of this phenomenon has really changed the nature of like the war on drugs, the nature of our country's response to addiction, and I think really for the better, actually. Like the kind of humanization of people that use drugs, regardless of how we got here, I think everyone can agree is definitely a good thing. And I would just say that the goals of kind of the racial justice movements and also the kind of public health campaigns to work on issues of addiction now really align, because these are unfortunately issues with a lot of inequalities. So I'm almost done with my talk. I just wanted to quickly talk about some of the clinical implications of polysubstance use, and maybe we could kind of chat about it. These are just my ideas and kind of some based on the nascent literature on these topics. So naloxone-resistant overdose is becoming a much more widespread problem, and for different reasons. So sometimes it's like with xylazine, where people are overdosing on a lot of fentanyl and a lot of xylazine. You still want to give naloxone, but there's this phenomenon where people will still be kind of, even though they've gotten a lot of Narcan, they're still not fully responsive. They can't protect their airway. And so there's all of these kind of other more like kind of first responder kind of approaches that are required, that our EM colleagues are so good at, like managing people's airways and, giving rescue breaths. And I think basically one of the take-home points is that unfortunately it's becoming increasingly more difficult to manage an overdose in a community setting. So without a healthcare professional, I think in places with like heavy criminalization that don't have like Good Samaritan laws, people are really hesitant to call 911 when there's an overdose. And so there's been a big push over the past decade in just having like training community members to manage overdose and give Narcan. But I think that's increasingly becoming a lot more difficult. Polysubstance use also really complicates withdrawal symptoms. And I think this is definitely something that's really important for psychiatrists, right? For folks who work with people that are physically dependent on different substances. We have really good data to manage opioid withdrawal with buprenorphine and methadone, but increasingly that's just not enough, right? Who's someone who's withdrawing from a lot of methamphetamine and novel synthetic benzos that we can't even detect with urine drug screens, and fentanyl is going to have a really different overdose profile from someone who's just withdrawing from opioids. And I think basically it's great, like the kind of move towards telehealth, very low barrier buprenorphine prescribing that we're seeing in a lot of the country. But I do think it needs to be paired with really close follow-up of unresolved symptoms and providing additional medications to manage other symptoms like anxiety. That can really make it a lot harder for people to really achieve cessation. And there's the most promising work for managing stimulant cessation, right? So helping people with stimulant use disorder stop using stimulants. There's like no medications that have panned out in any clinical trials, unfortunately, so far. Like you'd think can we just give people Adderall and will that replace their meth use? And unfortunately, it just doesn't seem to work empirically yet, but maybe different models might be useful. The one thing that's worked is called contingency management, which is basically a structured environment where you provide financial incentives for people to turn in clean urine drug screens. So basically paying people to not use drugs, which actually works really well, but is politically just extremely hard to sell to decision makers, and but has the best evidence. And then something that I think anybody who interacts with people who use drugs can do is counseling about the illicit drug supply. A lot of this information is not widely known by people who use drugs. There are drug checking programs opening up all over the country, which can provide a really helpful source of information so people can bring in their drugs, they can find out what's in them, they can tell other people who are exposed to these drugs. And like with things like xylazine, most people do not want to be exposed to something like xylazine, right? Which is like not approved for use in humans, really doesn't have, it's not like one of these drugs like fentanyl or heroin or morphine that, have had some kind of appropriate clinical uses and probably have some ways that they're wildly misused. But something like xylazine should just not be used in humans. And a lot of people, if they're equipped with the knowledge of what's in their drugs, will make safer choices. And so counseling about what's been happening in the illicit drug supply, and as clinicians feeling empowered to share this kind of information with patients and give them advice about how to stay safe can be really transformative. So with that, I would love to chat about any of this with everyone. All the articles I've referenced can be accessed here, and here's my email and here's my Twitter where I tweet about new papers. So thanks so much for your attention.
Hi, Dr. Friedman. That was a great talk. I really appreciate the points about like the different illicit substances entering the market. And I was kind of curious if you could speak a little bit about benzos and their role, kind of like currently, and like maybe if there's going to be waves of benzos in more illicit benzos entering the market. I don't know. Maybe that's a difficult question. Yeah.
Really good question. So I think benzos are one of those things that have always been kind of there, floating in the background at low levels. We know that they exacerbate opioid overdoses, but it's a lot harder to overdose on just pure benzos. Like they're typically found in combination with alcohol and opioids. That being said, I do think that's starting to change with the rise in novel synthetic benzos. So I'm not saying you should do this, but if you were to like go on Reddit and look at some of the, communities of people that are like new benzo enthusiasts, there's some pretty wild stuff that's happening. And a lot of these benzos are not even they're not scheduled, they're not criminalized. You can just buy them on the internet, and they're far stronger than alprazolam and the other benzos that we're used to. And so I do think what we're seeing is not so much, for whatever reason, benzos are not like taking over the country really, but what there have been in the epidemiological data is like these little outbursts where like there'll be kind of like a particularly dangerous form of benzos will hit them, like a novel synthetic benzo will hit the market somewhere. It'll cause like a lot of deaths in a short period of time, and then it'll kind of disappear. That is actually similar to what we saw with some of the initial fentanyl analogs. Like, for example, there was a period of time where carfentanil, which is like 100 times stronger than fentanyl, so extremely strong, was popping up in different pockets across the US, and it seems to have mostly died out, thankfully. So we've returned to just the like very dangerous fentanyl, not the like extremely dangerous carfentanil. And so far that seems to be happening with a lot of these novel benzos, but I will say they are everywhere. We do see them at the drug checking programs that I work with in California. And it's definitely something to be aware of. Like there's just a lot of patients who, especially kind of like savvy, nervous patients who don't get the level of benzos they want from their doctor, can just buy them online and get like something way stronger. So it is, I think, important context to have.
That's a really great talk. Thank you. I'm thinking about, I have two small kids, and I've heard some horror stories about, people traveling in an Airbnb, their kids got a hold of fentanyl somehow that was left behind from a party, or, people, their kids potentially dying. There was a kid that died at a daycare in New York City recently. So anyway, we have Narcan in our cars and one at home just for who knows what. But I'm thinking about, like, as a public health measure, have there been discussions or any cities looking at anywhere there's an AED that they also have Narcan, like in a grocery store or a library or those types of things?
Yeah, that's a great point. I mean, I will say, I think most of the pediatric deaths are still instances where people are intentionally taking a drug, but it's not what they think it is. But certainly there have been these cases of, kids getting into fentanyl that are, make the news and are like extreme tragedies. And more broadly, I think we really do need to move towards, kind of treating Narcan like a fire extinguisher. Like there should just be one, like, kind of everywhere. It's a drug that has been generic for decades. It's extremely cheap to produce. There have been a lot of problems in terms of making low-cost formulations available to people. I think like it did very recently become available over the counter, but it's not that inexpensive, unfortunately. But I will say, like, working with like schools in LA, there's, I think, a lot, like, attitudes are kind of changing in real time. So when I first got involved with a group of people trying to get Narcan into schools in LA, there was some pushback for people saying, isn't that like, kind of tacitly approving of drug use, or, things like that. And then over the past kind of couple of years, there's been a shift where now everyone's just like, of course we should have Narcan everywhere. And so I think you're absolutely right. Like, it should just be, I work with a group that just gives it out, and I usually tell people, put it in your like purse or in your car glove compartment or like wherever you're going to be, because it's just a good thing to have. And a lot of people who carry Narcan have just saved someone else by chance. So thank you for that.
There you go. Sorry. Hi there, thanks for joining. That was a great talk. I just wanted to add the Never Use Alone hotline. So for patients, for folks who are going to use, they can call a hotline, they can talk to somebody, they can be located, in case, something goes sideways with their use. It's a really helpful harm reduction technique, because we know people are going to use, but the goal is to prevent overdose deaths. And so someone will stay on the line with them the entire time. They'll talk to them, they'll ask them when they're using, and then if the person doesn't respond within X number of minutes, they will send out an emergency response team, and hopefully get them to the location as quickly as possible. So I tell all my patients about that too.
Yeah, absolutely. I saw a really great story on NPR about one of those hotlines recently. I think it's promising. I mean, obviously we need to make sure that people, like, when those hotlines have 911 go, and people won't be kind of criminalized when the police show up. But I think that model's been working really well in a lot of places. Well, thanks so much, everyone. I really appreciate the chance to speak. And I know residents are pretty busy, so we should probably give you your time back, but I will definitely stay on just in case. Thank you.
Thank you.
Thank you.
Thank you again, Dr. Friedman. And I will send you an email, but if you wouldn't mind sharing, do you mind sharing your PowerPoint so I can provide
Sure,
that?
yeah.
Okay,
I'll send that
so
over. Yeah.
okay, usually I do that and then provide them with a link to the video. So that would be awesome. I'll send you an email shortly, but thank you so much for presenting today.
Of course. Thank you for having me. I appreciate it.
All right, take care.
Bye.